Well, I think it's a good time to start. I see we have 41 participants. I'd like to introduce myself. I'm Jeff Donner. I'm an orthopedic spine surgeon in northern Colorado. I am presently the president of the Sacroiliac Medical Expert Group we call SIMEG. And it's an international group that initially started in Germany with Michael Dirks from industry and John Stark, an orthopedic surgeon who was very interested in helping patients with sacroiliac pain that did not respond to non-surgical means. From there, it grew and included some other notables like Volker Fuchs and Tom Kipsgaard in Norway, and then became more international with the inclusion of many of us, Dr. Polly included, and Tom Freeman. Recently, we've added trauma orthopedic surgeon, Dr. Woody Cross at the Mayo Clinic, and some Japanese colleagues as well. Our goal has always been to be the source for patients and clinicians, surgeons who are interested in helping patients with sacroiliac pain, which has been way too long ignored. And since now it's been more discovered after 100 years after it was initially promoted before the herniated disc was discovered, it has gained a lot of traction and a lot of education has occurred in terms of identifying this as a source of pain. Now, part two is now how do we treat them when our physical therapy and chiropractic colleagues and interventional and non-interventional pain physicians run out of answers. So that's why our surgeons are here today, and that's why the board is primarily made up of orthopedic and neurosurgeons, but we are certainly open to a very diverse group, not only from how we approach it in terms of our training, but also where we live in Europe or Japan or the United States. And the bottom line here is we're here to represent the patient's best interest, and how to get there is by having these types of discussions and education. So with that, I'd like to first have the slide for the meeting so I can introduce our speakers. I will help moderate this. We'll try to keep it fair and balanced. If there'll be time for questions at the end, but we're going to allow Dr. David Polly, who is well known and his credentials are outlined, to begin the presentation and specifically on following the data. Yes, I can see it.
Great. Well, thank you all for attending across the world. And I will share a little bit of a personal journey about sort of how we got here, and then something about prospectively collected data to date. My disclosures, which are relevant, I was not a consultant with any industry partners until 2018. From about 2010 to 2018, I had no consulting relationships. I obviously have other relationships and activities ongoing at this time. So my history with SI Fusion is I did my fellowship in 1991-92 at the University of Minnesota. And I was trained in the open Smith-Peterson SI Fusion technique. I returned to Walter Reed, where I did my residency and was chief of spine surgery. And I did what I was trained to do, but I was not happy with the results. I just wasn't able to get the outcomes that I had seen or thought I had seen, and said, all right, I need to try something different. As far as I know, I was probably the first one to do this about going to a CT scanner, because I wasn't trauma trained and wasn't good at doing iliosacral screws under fluoro. So I went to a CT scanner and put it in under CT guidance. It worked great for a year, and then it loosened. I tried several salvage techniques on that patient, but I couldn't get her better. And at that point, I said, I don't know how to fix this problem. I know how to diagnose it, but I just then sent them to my physical therapy and PM&R colleagues for non-operative management. Around the year 2000, I had a labral tear and had a debridement of that. And so my differential diagnosis of buttock pain got better in terms of including intra-articular hip pathology that was not radiographically evident. And I probably saw 50 patients a year that I sent for hip arthroscopy, and probably a similar volume of SI patients, but again, I wasn't operating on them. I came back to Minnesota in 2003 and maintained that same posture and referred them to my colleague, Dr. Mark Swinkowski, who was an orthopedic trauma surgeon, and he did open anterior SI fusions. In 2010, I had a patient come to me and specifically asked me to do an SI fusion using the iFuse triangular titanium rods. I'd been doing O-arm and navigation for a number of years at that point, so I was confident I could navigate the corridor, but I told him I had no idea about the outcomes. I had no experience with it, and he said he wanted it anyway, and I did, and that was the start of my experience with minimally invasive SI fusion. Prior to that surgery, though, I had been seeing these patients, and Jonathan Sembrano, when he was my research fellow, looked up a cohort of 200 consecutive patients who'd had no surgery on the hip, spine, or SI joint who presented to my clinic for back pain. And that what was very clear was that, sure, the majority of them had back pain, but there were a large minority that had other problems, and some lucky people had all three. And so the differential diagnosis of buttock pain is a significant component of any talk about the SI joint, because if we don't shoot at the right target, we certainly won't hit it. The next comment is that the SI joint pain has a significant negative impact on health-related quality of life. If 1.0 is perfect health and 0 is death, it turns out that SI pain patients who met the criteria for the clinical trials had a health-related quality of life of only 0.5, so very debilitating, commensurate with people who needed total hip, spinal stenosis surgery, degen spondees, and total knees. So in 2009, we had a meeting in Minnesota at a place called TRIA Orthopedic Center, where we gathered spine and pelvis surgeons to talk about how to make this diagnosis, what the problems were, and conjecture about treatments. And so these are the folks that I remember being there, and there were a number of others. And we all left smarter about the topic, but I wouldn't say we were yet smart on the topic. In the years 2010 to 2012, in the United States, the CPT code that was used for all of these procedures was 27280, which was originally developed as a code for open SI fusion. It was applied to all procedures done about the SI joint at that time, and generally covered by the vast majority of insurance. And there were no preconceived or pre-specified criteria. In 2012, the NAS representative to the AMA CPT committee recommended a new code for minimally invasive SI joint fusion. And on July 1st of 2013, a so-called T code or category 3 code was established. This is a process for new codes within the AMA CPT process. And once it became a T code, all commercial payers said it is now experimental, and that they all declined coverage, saying there was no data. Somewhere around this time window, the InSight randomized controlled trial was started, and at the University of Minnesota, we were a site for participation in that clinical trial. So the history then of the coding, which then drives the reimbursement, was that lateral MIS procedures were probably launched about 2009. There had been a series of screws and other techniques that had been described in case reports. And then we had the NAS recommendation and then the T code. And then after the T code was established, we applied for an AMA category 1 code, which then takes a significant process to go through to get approved. And then a work value has to be assigned to that code. And so this did not become a category 1 code again until 2015. In 2018, Blue Cross Blue Shield, probably one of the larger payers in the United States, recommended coverage. Blue Cross Blue Shield has an internal group known as Evidence Street, which does their own internal review of the evidence and makes recommendations. The various state Blue Cross Blue Shield associations are not obligated to follow this recommendation, but in general, most of them do. And so their recommendation at this point was that the minimally invasive procedure be covered, and that some of the Blue Cross Blue Shield participants decided that it was appropriate to give exclusive coverage for triangular titanium rods based upon the published evidence at that time. The RUC valuation process has an extensive background behind it. There's what's called a RASH survey and then a RUC validated survey, and that many of the clinical studies supported by SI-BONE as well as independent studies were used in the evidence generation and discussion in this process. My personal story is that I collaborated at my own expense with SI-BONE on evidence generation. I advocated through multiple professional societies that I had relationships with, advocating for support for this coverage. As a member of the American Medical Association, I was the one who by name was the representative submitting for a new Category 1 code, and I attended the AMA CPT committee meeting and presented the case for the Category 1 code. There was significant background work on this supported by SI-BONE, and at that meeting it was approved. I subsequently spoke to many insurance medical directors, sharing the data from two of the prospective clinical trials, and continued to advocate with the professional medical associations. And then I flew to CMS to talk to the federal payers, so CMS Center for Medicare and Medicaid Services, to advocate for federal coverage, which was granted. I had the opportunity to collaborate on a number of healthcare economic modeling studies looking at Medicare data, and even a study with commercial payers, including Optum. And these showed the cost effectiveness of SI-BONE over time. SI-Fusion over time. I again continued on the advocacy on a state-by-state basis. And the one area where we were not successful was the Washington State Health Technology Assessment, where the external review by a group called ECRI had recommended coverage, but the Washington State Authority denied that coverage. So the course of coverage over time looks something like this in terms of number of lives covered. And some of the payers were reluctant to pay. One in particular said they would not approve coverage of this until there was 5-year prospectively collected data in order to issue a coverage determination. When you think about this from the payer perspective, they had several wants or needs that were required for them. They wanted a procedure that worked. They wanted low revision rates, but most of all, what they wanted was an overall decreased cost of care after the intervention. So if the intervention led to more costly care, they weren't interested in it. If it led to lower cost, then they were. And so many of us worked to generate the data that they needed in order to be able to get coverage. So we recognized the pyramid of the levels of evidence, with level 1 being RCT, level 5 being expert opinion, with other reviews, economic studies, and biomechanics being somewhere in that milieu. And so this is sort of a timeline of the publication of peer-reviewed studies and coverage determinations by various organizations. So looking at patients with SI fusion in prospectively collected studies, recognizing that prospective studies generate different higher quality data than retrospective studies, not from a lack of effort on the people doing the studies, but based on the quality parameters with which the data is collected, that currently there are, that I've had involvement with, 3 prospective studies utilizing triangular titanium rods, INSIGHT being the US randomized controlled trial, where 141 patients eventually received the surgery. The IMEA trial in Europe, where 52 patients received surgery. And then the SCI-FI prospective open label study, where 172 patients received the implants and received surgery. And so that's 365 patients in the prospectively collected cohort. If we look across other implants, there are other studies and higher quality studies coming out. I don't have access to all of that raw data, but I am encouraged that the level of evidence is increasing. However, we still only have the 2 randomized controlled trials until Thomas Kipsgaard is able to publish his RCT versus surgery versus sham surgery. There have been various ways of looking at process improvement data, looking at reports of complications and tracking them in so-called P charts. And so this is a P chart from industry looking at triangular titanium rods and the mean rate of revision for malposition, and that it shows us that this is probably generally trending down, probably as a result of increased surgeon experience. And so the cumulative probability of revision over time has been studied, and we see that symptomatic malposition is probably less than 1%, and that all-cause revision is probably in the 2 to 2.5% range. In terms of other safety data, the best data that I've been able to put together about bleeding complications is they're probably in the 0.2 to 0.4% per year, and maybe 0.01% for gluteal bleeding. And where do I come up with this data? So in the prospectively collected data, there was 1 patient out of 365, so 0.27%. My personal series is about 285 patients now, and I've had 1 patient with a gluteal hematoma that developed after the surgery, and I can't comment whether it was arterial or venous. And so my rate is 0.35%. So that seems to suggest that somewhere in the 0.25 to 0.35 range is probably a reasonable number. If we look at gluteal artery injury, certainly that occurs in other procedures, and so it's a recognized phenomenon that hopefully knowledge of anatomy and technique skills will help us try to minimize this problem. There have been some safety data updates with post-market surveillance studies, and an independent review actually done by the group out of ECRI that presented to the Washington State Health Technology Assessment reported that they thought that the incidence of revision is likely no higher than 3.8% at 2 years. This probably compares favorably to other accepted spine and orthopedic implant procedures in terms of revision rates, in terms of published data. In terms of additional coding procedures, there has been one other activity in the space where a posterior approach with interpositional allograft bone has been assigned a T code as being different than a lateral to medial approach. So the prospective evidence for the efficacy of lateral to medial SI fusion that I have facility with includes the INSIGHT trial, which was the randomized controlled trial of surgery versus non-surgical treatment. And it showed that significant improvement with the mean improvements of 50 points on the visual analog pain scale and about 30 points in ODI. Disappointingly, the decrease in opioid use has been less significant, but the safety we've talked about a little bit already. The next trial, the IMEA trial out of Europe, prospective randomized controlled trial, a slightly better designed and executed trial as lessons were learned from the INSIGHT study. And the aggregate data actually looks very similar in terms of improvement, direction, effect size, and percentage of patients improving. And patients who respond after crossover seem to get commensurate benefit to those initially randomized to the surgical treatment. In the IMEA trial, a functional outcome score was included, looking at walking 500 meters or more, and we see the improvement in that cohort. The next trial to talk about is the SciFi trial. So this is a prospective open label study, and the 2-year published data, again, appears to parallel the other 2 studies. And so if we pool this data, what we see is consistent effect size and direction in the trials. This was published with Julia Stengler as the lead author in a publication in Spine. The lowest trial, in response to the requirement from industry for longer-term follow-up, the centers that had enrolled patients prospectively were contacted and an attempt made to follow these patients for what were originally designed as 2-year trials to see if 5-year data could be obtained. And for a number of patients, this was able to be done. And what this study demonstrated is that if the patients had benefit, that it appeared to be durable out to 5 years. Again, the opioid reduction is there, but it is less optimistic than I would have hoped for. The last trial is a prospective study looking at a slightly newer design, triangular titanium rod. And again, this paralleled the other study findings. It appears that it's similarly safe and effective. In pooling the data in terms of surgical revision and wound infections, the infection rate is low, probably because this is a minimally invasive procedure. The initial revision surgery due to implant malposition is in that 1% range in the prospective cohort, and late revisions at about 2.8%. So that's the prospective data that I'm aware of in terms of safety and efficacy. And this is a summary data table of that cohort of patients. So anytime we talk about risks, we probably ought to stratify that because every surgical procedure has some risks. And so as I tried to think about it, the best comparable analogy of a procedure that's radiographically driven rather than direct visualization driven is probably a transpsoas interbody fusion approach. And so we see vessel injury rates of 0.4% in the transpsoas cohort in a literature review, and hematoma rate of about 1.7%. So maybe not too far off from what we're seeing in lateral to medial SI fusion. So my summary of this data would be that no surgery is risk-free or 100% effective. We use the best data we have to inform both ourselves and our patients, and over time we look to improve. I think the onus is on the advocates for any new intervention to provide as high quality data as possible on the safety and efficacy. And I look forward to vigorous, thoughtful dialogue about this topic, and I'm thankful for the opportunity to participate today.
Thank you, David. That was very enlightening, and we appreciate your point of view and your experience. I've realized that just the group of us that are participating, yourself, myself, and Tom, almost represent 100 years of experience, because I was first diagnosed with SI joint pain at Shriners Hospital in Philadelphia when I was 18. So it goes from there, and I've been performing SI surgery for about 30 years, and I know you have a very long history as well. So that's really good information of why a lot of us are here today, not only to help our patients, but to maybe understand our own problems. So we really appreciate that background. And then I would like to move on to our next speaker. Would that be David? After David, is that Tom or Dorothy?
That would be me.
Okay. So I'd like to introduce Tom Freeman. He's a neurosurgeon at the University of South Florida, and he has a lot of experience in this area as well. And he had some very serious safety concern issues that were brought about by a complication during surgery, which always gets our attention and makes us more focused. So with that, Tom Freeman, Dr. Freeman would like to make his presentation, and then we will have a lively discussion as the time evolves. Tom?
Okay. So I'll be talking about safety concerns with the lateral approach to the SI joint, with many of these issues applying to all devices that come from laterally, and with a focus on the SI bone iFuse device in particular. So my question is, are we there yet? Is this the final iteration of where we're going to be going with SI joint surgery? Conflicts of interest, I actually have received no compensation for this talk. I have no active conflicts of interest with companies, but I do have a contract in discussions with Tenon. In terms of IP, I have IP in this space designed for the safety, efficacy, variability, reproducibility, and other concerns with the lateral approach. So those are my conflicts. Conflict of interest mitigation has been extensive with both internal and external reviews, including with David Polly for this talk. All perspectives are mine and not that of my university or SIMEG. This has been under the guidance of USF Deputy General Counsel, and David Polly will be allowed to refute everything I say at the end of this as well. I always enjoy my conversations and discussions with David Polly, because I think between the two of us by the end, I think there's a pretty good understanding of pros and cons of numerous perspectives. So by way of introduction, David Polly has done a remarkable job with numerous RCTs as well as other trials. And David Polly and SI-BONE have done an enormous heavy lift of building an underserved SI joint market for an orphan disease that was not adequately treated for almost 100 years. There's been a lot of innovation in physician education, and I've used their product a fair amount, and I've had quite good results until I had an unavoidable near miss that triggered the need for this talk. My near miss was an absolutely routine case. I was enjoying myself. Things were going quite well. I was putting in my third triangular implant, and it was about halfway impacted when I got a gush of a huge amount of arterial blood. I had to make a choice to pull it out or finish impaction before I could control the bleeding, and decided it would be faster to keep going. And within a 1-minute period of getting the implant in and controlling bleeding, I lost 51% of the total blood volume for that patient, which is a class 4 hemorrhage. This is a near-death type of process. That's a near miss. So I had to report this to the MOD website, and I gave those exact details. And this was adjudicated by the manufacturer on the MOD website, saying that bleeding is a known inherent risk of surgery. So patient abnormal physiology may have contributed to the adverse event, and the rate of severe bleeding is low, and no action is required. So this is the starting point for the discussion. I would just like to start off by saying there's numerous approaches to the SI joint. We're going to focus on lateral in comparison to the posterior extra-articular or the distraction interference method versus the posterior inferior methods, with a focus on the lateral approach safety issues. But what they all have in common is blood loss is usually minimal for all of them. They're either minimally invasive or minimally disruptive mini-open procedures. They're generally well tolerated, and device failure, when it happens, is usually on the soft sacral side. But not all devices and approaches are the same. There's different designs, materials, surfaces, approaches, and risks specific to the numerous steps in the process. And there's also different mechanisms. There's compression, stabilization, and distraction interference. And there's merits to each one and caveats to each one. The main goal, of course, from a safety perspective, is to avoid risky areas, including, obviously, the neural foramen, the spinal canal, and the intra-abdominal part of, that's right in front of the sacrum and the ilium. So what are the benefits of the SI-BONE iFuse device? It was the first FDA-approved device that was widely adapted internationally. No need for BMP. It's minimally invasive, minimal blood loss, RCT data supporting good pain control and patient satisfaction, evolving durability, and it's the only approach out there with quite robust randomized clinical trial data.
I know nobody wants to hear.
Somebody has their microphone on. Thank you. Okay, so this is the type of data that we've been seeing with the confluence of curves of improvement and evolving durability data. There are over 30 companies in the space. Almost all of them use a lateral approach one way or the other. And so many of the concerns of this talk apply to these devices as well. So Bruce Dahl reviewed the adverse events as reported voluntarily on the MOD website. And this paper came out in April of 2022, and there were 1,100 reports. At the bottom, you'll see that there's over 1,500 reports that are currently reported in a new publication that just came out in 2022. So there's a very rapid accumulation of SAEs being reported. And in Bruce Dahl's article, there were 3 patients with SI bone procedures that died, all associated with hemorrhage. 50% were malposition, 58% with root injuries, 92% with revision surgery, and almost 60% of SAEs were attributed by the company to surgeon error. When I've looked at the site myself, I've found over 50 significant hemorrhages, 40 pelvic fractures, anterior sacral cortex and intra-abdominal violations, and device non-unions as well. So since the vast majority from SI bone, is this because it's a problem with the iFuse, or is it because more cases have been performed with this device? There have been more cases in clinical trials where SAE reporting is mandatory instead of voluntary. Early adapters become more facile. There's new advances that will be coming that increase safety, and surgeon error is cited with misplaced pedicle screws. Is this the same thing? And to date, there's minimal comparative RCT data in other technologies that may minimize that reporting. But even with all of these caveats, there's an extensive history with several of us internationally that have used other techniques with other devices that are either FDA FDA approved devices or approaches that have been used successfully and safely with likely diminished risk profiles, although the actual numbers need to be proven going forward with prospective studies. So the purpose of this presentation is to demonstrate the classes of elevated safety problems with the lateral approach in general, and the SI bone iFuse device when relevant, compared to other SI joint devices using the posterior distraction interference method or posterior inferiorly. And this doesn't include ilial bolts or S2AI screws used at the base of constructs. So I will touch each one of these. These are just the different topics that I'm going to touch on, just to let you know there's a bunch of them. And I will advocate that these elevated risks are specific to the lateral approach. These are not general surgical risks. So the first one is unavoidable and unpredictable neurovascular injuries specific to the lateral approach. These are unpredictable injuries to the superior gluteal neurovascular complex, which lays on the lateral side of the ilium, and other approaches are either within the ilium or on the medial side of the ilium. So this is really a lateral approach specific complication. And this includes 3 hemorrhages, including death on the MOD website. Anecdotally, I've heard of several others. And there's one near miss in my hands that we've already discussed. And the reason for this is pretty self-evident, that the implants coming from laterally are in the same region as the location of the superior gluteal neurovascular complex. And there's a lot of variability in this, as reported by Lateral. And this contributes to this problem. And this is reported by College, who found that in a cadaver study, 18% of S1 screws alone impaled the neurovascular complex. And of course, this is with 1 screw, not 3, which would triple that risk. Eastman projected a 10% injury rate for S2 trauma screws and cites other reports with 25 to 45% injury rates, and correctly suggested alternative trajectories may lower injury rates and pointed to attention not only to bony corridors, but also attention to soft tissue corridors. So this is a picture from Collins down in the bottom right showing what this type of injury looks like. So injuries are even more likely if there's a dysmorphic pelvis where the superior gluteal neurovascular complex migrates more posteriorly, and it also is magnified with more caudal implants at S2 and the S2-3 level, which is closer to the proximal and larger origin of the superior gluteal artery. So the key thing is that this is unpredictable and reported to be unavoidable by Maxwell. So this is a problem that even with good surgery and good technique will still be unavoidable in some situations. Next, SI joint dysfunction is accompanied by transitional vertebra or dysmorphic pelvis in almost 30% of patients, which will increase this risk of neurovascular injury in this population. So calling this abnormal pathology when it occurs almost 30% of the time means this is actually quite normal in SI joint pain patients. Cadaver studies deviate from what is clinically reported, where only about 3 to 4% of the cases have bleeding that's easily controlled with gel foam patties. And David Polly has pointed out to me that this should be easily controlled using gel foam patties rather than flow seal, which can cause an air embolism or a foreign body embolism. And the superior gluteal nerve and artery are mobile in patients. And there's also tissue spreaders and tissue protectors as opposed to a cadaver study. And these types of things may explain the difference, but it's still present in 3 to 4% of cases. So the key thing is it can occur in an unpredictable manner, and blood products are generally not available in the operating room when this happens. Not only can you get bleeding in the operating room, sometimes blood can sequester and not even come out the wound. And this is a patient from Maxwell's article that had a 24-centimeter hemorrhage. And so measuring blood loss based on what goes into the suction versus starting and finishing hemoglobins really does matter, because a huge amount of blood can sequester into soft tissue. And this is the picture of where the broach caused the bleeding in that patient right next to the superior gluteal artery. So it is a random event. It's infrequent, but when it happens, it's a big deal. So this is from the CFI trial from 2016, where there was one outlier with 800 cc's of blood. This is from the Symmetry trial, where there was one patient with 1,500 cc's, and my patient had something in this range as well. So it's a rare injury, but it's the lateral approach is the only one where these structures are in the direct line of the approach. What happens when you damage the superior gluteal neurovascular bundle? You can get neural denervation to the gluteus medius and minimus, tensor fasciae lata, and some innervation to the piriformis. You can lose some vascular supply to the gluteus maximus muscle. And the impact of all of this is, first of all, that there is no safe corridor, according to Mattson, for a horizontal S1 screw if there's transitional anatomy. And Maxwell recommended that there's pre-surgical planning to avoid iatrogenic injuries, including a CT angiogram or catheter-based angiogram with image fusions. And this is a big deal. That's a lot of work, and it's a challenging part of the workup. The next issue that I think contributes to this is that the tissue protector for a large triangular implant is much larger than a typical predicate trauma screw device that's small and round. And this, because the tissue protector is rectangular, but the pelvis is not, leaves a gap on the caudal side of the protector. And this is the actual case of my implant where I got the bleeding as I was impacting. And you can see when the guide tube is docked on the ilium, there's a large gap where soft tissue can creep into the implant and have a shearing injury leading to bleeding, which is what I believe happened during my case. The bottom device was in this location, which is very similar to what SI-BONE has published. This is a picture from the Lois trial, and this is a picture from their teaching guide. So I think the technique was within the realm of what is being taught by the company. And so what's critical for teaching for the lateral approach, you need to have good teaching of anatomy of both bony and soft tissue quarters, how to manage bleeding from the SGA, and discussions of other surgical options that may not have this complication risk. Now, it is a low risk in terms of the numbers, but it's a big one when it happens.
New Jersey.
I did, they already arrived, so then when I realized that I said.
We have a microphone on, please.
I ordered them yesterday to come here, and they came right away.
Next is life-threatening bleeding is a risk specific to the approach, and this may be magnified not only by the lateral approach, but the iFuse device in particular, which is larger and triangular with the tissue protector issues I discussed. And this bleeding, therefore, is not a general risk of surgery. It's specific to the lateral approach and magnified by this larger device and tissue protector issues. And life-threatening bleeding is not an inherent risk of the distraction interference approach. I've never seen a case, nor has John Stark. Between the two of us, we have probably close to 500 cases, is my guess, and just have not seen this ever happen because we're nowhere near that artery. So action is required. The next is, what are the neural structures that direct risk besides the superior gluteal nerve? There's obviously the L5 root at the top of the sacrum and the S1 root, in particular in the neural foramen. This becomes a particular issue with the sacral ala anomaly with dysmorphic pelvis. And even with normal anatomy, you can see the guide pins. This is from the technique guide, come quite close to the L5 and S1 root. And if you do this enough, injuries to those are not unexpected. And this is from the college article showing what it looks like when a screw goes superiorly, even with good imaging in the lab. Next is risks of intra-abdominal injury, which get magnified when 2D imaging is used rather than navigation, and particularly when CT guided planning is not done, because many people do not get a CT before surgery. And this becomes magnified once again with the dysmorphic pelvis. And so if you have a lumbarized S1, the SI joint is even smaller, making it even more challenging to get devices in. Likewise, with transitional anatomy, the upper segment of the S1 quarter in a dysmorphic pelvis can be variable, and so one has to be very careful in knowing your anatomy with CT planning, since dysmorphic pelvises are so common in patients with SI joint pain. So this is a patient where there was a dysmorphic pelvis, and the device on the right side of the image right here has a normal trajectory into bone, but because there's some dysmorphic elements here, it ends up in the pelvis, where the guide pin and the tip of the catheter of the device ended up in the pelvis. And then here's another case where 2D imaging was used, and it looks like the top of the sacrum is in a pretty reasonable location, but there's a little dip laterally that's easy to overlook. And this is what the device looked like when it was placed from laterally, violating the bony corridor. And here's another device on the same patient that ended up missing the ilium altogether. And you can see drilling with blood and air going all the way to the lateral side of the L5 vertebral body, with blood into the psoas and the psoas plexus, which lives there. And when the psoas plexus gets tethered by a drill, it can tether caudally to the genital branch of the genital femoral nerve and rostrally to the conus. And this is the flaccid bladder this patient had, and these are the signal changes in the conus that this patient had. The patient could have had even worse because the iliac artery and vein are right there as well. So instead of the lateral approach, I think it's reasonable to consider alternative approaches to the SI joint for all index operations with patients with a dysmorphic pelvis due to these unpredictable neurovascular injuries that accrue to the lateral approach. And the risks are likely to be even higher in general practice because fluoroscopy may be used exclusively as opposed to clinical trials where many of the patients receive their device with image guidance. Dysmorphic anatomy is difficult to image in 2D. Many patients in the community are elderly with poor bone quality that may have not been part of the trials because of exclusion criteria. Type and cross blood is generally not utilized in our outpatient surgery centers, and trauma surgeon and IR backup for superior gluteal artery injury are generally unavailable when these are done in the outpatient setting. The next category is bone density issues. The sacral ala centrally is much softer than the central body of the sacrum. In fact, it's 9 times less dense in the central ala than the center of the sacrum. So at best, you can only get a device into the body of the sacrum at the S1 level, but the longest device available in the iFuse set is only 70 millimeters, which will barely reach the lateral aspect of the body of the sacrum. So the bottom line is another common element of all lateral approaches is their anchoring in the very soft sacral ala. So if you destroy the sacral cortex and rely on anchoring in the soft central ala, this is not as strong a situation biomechanically as one would like. And so we've all seen these types of lucencies on the sacral side, which is where all devices fail. These are other devices showing a similar type of problem, as well as with air balls. This is from Woody Cross. And so is predicate data appropriate? The predicate data is safety data from S1 and S2 round small trauma screws that reach all the way to the S1 body in a self-healing pelvis following fractures. So the device only has to be stable long enough for that fracture to heal. The other predicate device is the EndoFuse device that was bought by Wright Medical and has been bought again. But this was for an ankle stabilization device that lacked compression across a decorticated joint, which was the other standard of care at the time. And this device is no longer sold. It's an obsolete device. So long-term durability risks are the next issue in the absence of a bony fusion of the sacrum to the ilium. There's obviously evolving durability clinical data, and radiologic landmarks are a surrogate marker. I get that. But I think it's important to look at the data, which is that at 3 months, only 16% of implants have lucencies. At 6 months, it's 26%. And by 24 months, it's 43%. As patients age and develop osteoporosis, we really don't know. And I'd like to show a patient of mine that had a SI joint fusion with a distraction interference device placed in that over 8 years developed osteoporosis leading to an osteoporosis compression fracture, but the device has held up, the fusion has held up, and the SI joint pain for this patient remained between 0 and 2 for 8 years, even in the setting of evolving osteoporosis. So let's talk about what a fusion really is. There's fixation, which is a device that spans two segments and immobilizes them, typically used in trauma where there's a fracture that will fuse. Then there's arthrodesis, which is a surgical fixation of a joint where the operation is designed to fuse the joint by promoting bone proliferation. Then there's ankylosis, where you immobilize the joint and gradually over time, it fuses spontaneously, but that's not a surgical fusion, that's a delayed ankylosis. And this can occur with surgery or with disease or trauma. So this is obviously not an SI joint fusion, but it raises a discussion about what is it when you have a device that integrates with bone on one end, integrates with bone on the other end, and then has to be viable and not break over millions and millions of cycles. This is a novel mechanism, but it's not a joint fusion. So this is similar to what SI bone does, but this is not a predicate device. So when you have a lateral device that spans from the ilium to the sacrum, you need a integration of both sides of the device into the sacrum and ilium, and the device has to be durable for millions and millions of cycles in the setting of evolving osteoporosis. This is really a novel mechanism. And it requires unproven bony ingrowth, on-growth, and through growth to both ends. This is a novel mechanism, and this has a tremendous amount of merit, but is it a 510K mechanism? And is this an appropriate 510 clearance? So what is transfixation? First of all, the word transfix doesn't exist. Transfixation doesn't exist in Dorland's medical dictionary, but to transfix means to hold motionless. And this would infer that the device bridges both sides of a joint and prevents motion. So in the absence of a fracture, this is really relying on ankylosis. It's an ankylosing procedure from a technical point of view. The FDA guidance issued in 2000 states that the document defines the fusion as evidence of bridging trabecular bone between the involved motion segments. And so I think that's something that we all understand. So there's no bony fusion of the SI joint. There's no joint preparation. So the work is not done for doing the preparation, and there's no compression across the joint. This is a fixation process without an intraoperative intention to perform a bony preparation or fusion of the sacrum to the ilium. So, this is a concern about whether there is an actual fusion. So an analogy in America would be if you have one of these modern bone surface devices placed in the cervical spine with no hole in the middle for bone, can that be categorized as a fusion? And the FDA does not allow that. There has to be a window in the device. So the 510K mechanism of FDA approval requires a true bone fusion. Likewise, posterior cervical fusions were brought from France to America using the Roy-Camille technique. And in that description, cervical plates and screws were used without a bony fusion, just placing screws to stabilize the small facet joints, which remarkably ankylosed in a high percentage of patients. So this raises the question of how do we fuse? Now we add bone to these joints to raise the rate of fusions. So this is a 5-year outcome looking at ankylosis, and there is some bone in the joints where those red arrows are, but are these completed fusions? To me, I see lucencies. I would not call that a completed fusion, and there was certainly no joint preparation and no bone placed there intraoperatively. So the vignette that the AMA now has approved for the SI bone device with the 2729 coding is removing cartilage on the sacral and iliac side of the joint, direct visualization, and debridement of the joint. And I would just like to point out the obvious, these are just not done in the procedure, all three of those elements. The sacral cortex is critical for the stability, given that the terminal end of these devices is within the soft sacrum. So if a surgeon decorticates the joint, like the vignette description, it's easy to infer that this would weaken the construct to the point of not being equivalent to the predicate trauma screw device. So the next category is lateral approach can cause myofascial injury and disruption of the kinetic chain. The lateral approach goes through fascia, gluteus medius, and gluteus maximus muscles. Also, there can be damage to the superior gluteal neurovascular complex, leading to damage to muscular structures and causing abductor weakness and disruption of the kinetic chain, as well as other myofascial pain, and you can get gluteal compartment syndrome. So all of these can lead to walking difficulties and pain. We no longer perform iliac crest bone grafts due to kinetic chain disruption, severe pain, risks to the superior gluteal neurovascular complex, and we now have other safe alternatives. So it's reasonable to ask the question, are these lateral approaches going to become a rarity in the same manner and for the same reason? The next category is a unique mechanism of creating pelvic fractures. There's about 40 fractures reported at the time that Bruce Dahl accessed the MOD website, and 90% of all of these fractures are reported with the SI-BONE iFuse device in particular, which may be because of the number of cases done, but also because of the large size of the implant. And it's not known if these are stable or unstable fractures. But when you look at the number of devices placed laterally, particularly after revisions, you can see how there's a nidus for a fracture, similar to when granite is split by making numerous holes in a row. This is another form of pelvic fracture from that Woody Cross sent me, where 5 devices were placed, creating an incredibly stiff lateral sacrum, leading to a medial pelvic insufficiency fracture and a need for a revision. This is another case where devices were removed when they failed, where there was a pelvic fracture in the region of the devices that were removed. And this is the attempt at a distraction interference rescue with bone placed into the fracture site. So the next issue is the difficulty of doing these revisions. Oh, wait, I'm sorry, there's one more category that before we get there, there's a unique mechanism for disruption of the joint. 15 to 20% of patients in the published SI-BONE data have no improvement, and many more have suboptimal improvement. And 6% of patients in one trial were worse at 6 months than before surgery, and 10% of patients that could ambulate before surgery had difficulty ambulating after surgery in the CFI trial. So can we do better than this? So what are the mechanisms contributing to reported worsening in a small subset of patients? It can be damage to the L5 or S1 root, damage to the superior gluteal neurovascular complex, disruption of the joint itself at S1, S2, and S3, where the device passes through. And if it fails, it leaves holes in the joint there. Or failed unrevised devices and pelvic fractures are some of the possible mechanisms. And all of these factors are not part of the mechanism of a distraction interference operation or posterior inferior operation, but particularly the distraction interference technique, which is extra-articular, leaving the anatomy of the sacral and iliac side of the SI joint completely intact. So it should not exacerbate the SI joint dysfunction in the same manner. I think the need for CT planning is necessary for all methods of SI joint surgery, not just lateral, but it helps determine the safest and most effective procedure for an individual patient and helps you avoid getting into places you don't want to be, including previous bone graft donor sites, such as these 3 examples. So Maxwell recommended that a CT angiogram for the lateral approach be performed in all cases. He takes it one step further in the recommendations for preoperative imaging. The next category of issues has to do with variability in outcome. You can measure outcomes with a group analysis of the total improvement for the group or the number of patients that reach a clinical level of improvement. If you set the bar at a 20% level of improvement as being the minimal clinically relevant improvement, that's a pretty low bar because most pain studies use a 50% improvement. And I would argue that we want to have a goal of having greater than 50% improvement in up to 95% of patients, similar to knee and hip operations. And the issue is if you use a low bar, it can be deceptive as to what is really happening. So if you say that 80% of patients reach a 20% improvement, that doesn't reach the threshold of even placebo effects and variability from day to day and variability from month to month. Kipsgaard's upcoming placebo-controlled trial will give more light on this type of topic. But the primary endpoint is a similar linear scale rather than absolute binary scale. You're better than 50% or you're not, which I would argue is the more important endpoint with pain studies. If you look at the number of patients that had a 50% improvement, it was in the 50% range, not 80% range, where I have available open data for that. So if you look at the trial data, it looks pretty convincing, but when you look at the fine print, it's a 2-point drop from baseline. And this is the actual scatter plot from the INSIGHT trial, courtesy of SI-BONE. And you can see a lot of patients have either less than 20% improvement, one here has worsening, and some have suboptimal. So these are tough rescue operations, and that's a lot of patients. So it's depending on how the data is reported, you get very different impressions, and the Christmas tree type of presentation is really important. Standard deviation has been reported in about 3 reports, one of which is a case series, and it can be about a 2.9 variation. So if you're only getting a 2-point improvement with a 2.9 point standard deviation, a lot of this becomes noise. And if you look at where standard deviations are reported through all different studies, all different types of surgery, there's a huge amount of standard deviation. So how do we minimize this variability? That's a critical part. Improvements in narcotic use, not necessarily reproducible. Return to work, there's no robust improvement, with the caveat a lot of this, these patients have been disabled for numerous years, and in any disability that's prolonged, going back to work is difficult, but there's certainly no smoking gun showing some robust improvement in other indirect measures as well. So how do we revise this? Lateral approaches are more challenging, and the SI-BONE technique, because it's not threaded, is even more challenging. Of course, improvements with revision rates improve with experiences was just pointed out, but it's particularly challenging for the SI-BONE technique because it's not threaded. Removal leaves large contiguous holes in the ilium and sacrum with concerns about possible pelvic fractures. Anterior rescue surgery through the abdomen is very challenging and risky. Not many people do it. And surgeons performing these types of risky revision operations or complex operations are poorly compensated, and they're in critically short supply and can't meet the need if 15 to 20% of patients have clinical failures. So these are big operations. They're tough, poor revision, lots of risk, not many people doing it. This is another case from Woody Cross. This is what his revision looked like. This is a Vic Patel revision, but there's just not that many David Pollys or Woody Crosses or Vic Patels doing revisions in the United States and internationally. The next thing is, in many cases, these devices, when they fail, block important supplementation rescue corridors, like the S2, ileal corridor for placement of ileal
I'm
bolts.
having a problem deciphering between.
Please turn the microphone off. Between the S2 ileal corridors, it can block supplementation to the SI joint using the posterior distraction interference technique. It can block the posterior inferior corridor as well. And this is an example of an obviously too short device that failed, but good luck getting a device in the posterior inferior corridor on this one. And these devices block the distraction interference corridor. This is a case from Puyallup County where the devices blocked a S2AI screw for his planned deformity correction surgery, and he had to anchor this in the soft sacral ala. Device failures have challenging revisions and challenging supplementation options. So is a low revision rate fair to report if the device that fails is challenging to revise and the surgeons doing this are in short supply? So when you add that to a high degree of variability in the outcome in 15 to 20% of patients, and revisions and supplementations are not readily available or feasible, this becomes a problem. And this combination of factors leads to a class of harmed patients when there are other FDA-cleared revisable and supplemental options. So what am I supposed to tell this guy? This is one of my patients. He's a minister that in 2016 had a failed operation, and for 6 to 7 years, couldn't find a surgeon that wanted to take this on. And he finally ended up being sent to Mayo Clinic for Woody Cross to revise him, and he's now on the schedule. But Woody's got a series of 60. When you have hundreds of thousands of patients getting the surgery, there's just not enough surgeons doing these types of revisions. They're challenging and risky. So based on this particular problem, a 20% failure rate with difficult and poorly available revisions, this creates a class of patients that end up with poor outcomes. So for that reason, I think it's reasonable for surgeons to reconsider recommending a lateral approach for all primary operations, unless they're willing to do that revision themselves when there's other FDA-cleared options that are safer and easily revisable. They're designed to be revisable. The next category of risk is asking, are these surgical general risks, or are these a system and process error? So the specific risks that are magnified in the lateral approach, just to summarize, are the damage to the superior gluteal nerve and artery via direct exposure from the medial, from the lateral side of the ilium, as opposed to other procedures that are medial to this. Neural injury at L5 or S1, which is not a general problem for the distraction interference or posterior inferior techniques. Intra-abdominal violation has not been reported, particularly with the distraction interference technique, which is miles away from there. Death due to hemorrhage has not been reported with other techniques, even with a 10 to 15 year history. The tissue protector for the iFuse device in particular is problematic. A unique mechanism of pelvic fractures, challenging revision options in 15 to 20% of patients where there's a failure, when other methods have several easy options, and potential for clinical worsening because the SI joint itself is disrupted. So this many types of unique complications, I do not advocate are surgeon error, nor are they general surgical risks. So does this rise to the level of a training process and system error? This is an important question that must be addressed. If you go to the iFuse website, the only place where I saw specific risks mentioned is, ironically, in the patient portal, where it says the specific risks that are specific to the iFuse device include local injury to the pelvis, increased pain, migration, failure, breakage, stress fractures, and need for additional surgery and removal and repositioning. This is the specific risks on their website in the patient portal. Mentioned as a general risk, however, is vascular injury. They didn't mention this as a specific risk. I think this is a specific risk, and not mentioned at all as intra-abdominal injury, safer options, limitations on revision options, and kinetic chain disruption. So in the general population, looking at Humana cases, Chang et al. Found that the rate of complications is much higher, it's 16.4%, and this complication rate was reported to be more in line with complication rate in actual practice. And then when you get to an outpatient surgeon center level, this may even be magnified more, where fluoroscopy is used, type and cross blood is not in the room, and expert backup is not present. So when we talk about a risk-benefit ratio, it's really important to accurately report not only global outcomes, but the number of patients that don't reach that level of 50%, the variability, how do you rescue these patients, and what are the accrued risks? There are some teaching safety issues as well that apply to all companies, not just Lateral, but that education is limited in academic centers because most of these cases are done by private practice physicians, and academic centers are actually trailing. And so there's not a large cohort of people that have been mentored and had extensive experience in a mentored relationship. Manufacturers do a lot of the teaching for that reason, but they don't have any responsibility or capability for certifying proficiency. And it's not possible in a 2 to 4 hour course to teach people about the highly variable pelvic anatomy and not only bony corridors, but soft tissue and vascular corridors. So is MIS joint surgery safer and more effective than mini open surgery? That's another line of argument. But the studies that were used for making these comparisons were old school and not equivalent studies. In Smith et al., minimally invasive was compared to open surgery done in old school methods, multiple methods with concomitant lumbar fusion. So comparing blood loss is just a non-starter because they're not even equivalent. The next study was comparing the iFuse technique to an open anterior operation with a 20 centimeter ilioinguinal incision. This is not equivalent to what is available. John Stark was not asked to participate in these studies, and Jeff Donner refused to because of contract limitations on controlling data.
Got this wired scan.
Please turn your microphone off. So this is just to catch everybody up that is not aware of the distraction interference or posterior intra-articular technique. It's quite simple. It's a mini open, minimally disruptive technique that does not go through muscle and is on the medial side of the ilium. There's nothing down there that's risky except the medial side of the ilium and the lateral side of the sacrum. And in my hands, 83% experienced greater than 50% improvement in VAS scores, durable for 5 years. If we used an 80% threshold, if we used a 20% improvement threshold, 94% of those patients reached that threshold, and EBL is generally well less than 50 cc's. These are all the other secondary measures that also improved, and bilateral surgery compared favorably with minimally invasive surgery, with only about 11% of patients requiring bilateral surgery when they had bilateral SI joint pain. The fusion rate was about 90%. Admittedly, this required BMP to achieve that. And the other thing is we were able to revise those patients where the fusions failed And I think the ability to revise is not a sign of failure. This is a sign of moving in the right direction, because when you have a 20% failure rate, you have to be able to revise. So easy surgical revision is critical. So let's talk about variability. After the learning curve of my first 11 patients, only 2 of the remaining patients had outcomes with less than 50% improvement. So compare that to the variability in the prospective clinical trials. So controlling variability and having easy revisions when there's a failure is critical for reaching that 95% level. So SI-BONE is a first to market medical device, but first to market devices generally disappear. It's based on the in-bone technology by Mark Riley that is obsolete in the foot and ankle applications. So is the iFuse device going to follow the same path? There are numerous ways to improve it. And I think the new technology has helped improve the technology in terms of fusions, at least in my experience. I'm looking forward to seeing long-term data about that. But the tissue protector clearly can be improved. You can stimulate the guide pin. You use a microdoppler probe, 3D imaging with vascular studies and navigation, improve teaching of neurovascular risk mitigation methods and damage control management, focus on orthopedic trauma surgeons with mentored training in the lateral approach. And of course, the placebo-controlled trial will give us a lot of information, and that's coming up next year. But even with all those improvements, the risks that will continue are risks to the L5, S1 and superior gluteal nerves, risk of hemorrhage that's unpredictable and unavoidable, even with good technique and lots of experience, intra-abdominal violation, damage to the kinetic chain, pelvic fractures, a continued 15% failure rate, and challenging revisions. Those are here to stay. Next, let's talk about disclosure concerns. The post-market analysis that reported 3% or 4% complaints with radiologic haloing and recurrent SI joint pain in a low number of patients. Those that did get nerve impingement, a large percentage of them developed neuropathic pain. So overall revisions were 1.8%. On the other hand, are doctors being given adequate disclosures, such as what I've tried to do with this talk? This talk, in my mind, is the beginning of an open discussion of disclosures that we all need. And this is the type of information that doctors, payers, investors, the AMA, the FDA, and the SEC all need to have with tremendous clarity. I think, ironically, patients have it the most clear disclosure of what is a device-specific complication, but I think even that was incomplete in the respects I discussed earlier. So to make a risk-benefit profile, you need to not only obviously know benefit, but also operative risks, long-term risks, variable outcomes, clarifications of reasons for the large number of clinical failures and small number of revisions, relative risks and benefits compared with other devices, and all of these things are critical. So hopefully this talk will begin this dialogue. So the recommendations based on what I've presented here and a consensus of all the different papers that we've cited, as well as discussions with my colleagues, is during the informed consent process for the lateral approach, providers should consider discussing these unpredictable risks to the superior gluteal nerve vascular complex, including denervation to gluteal musculature, as well as death from hemorrhage, and that there are other methods that can mitigate these risks. The next is that due to the unavoidable and unpredictable nature of these injuries, 2 units of packed red blood cells should, at least in my mind, be present in the operating room for all lateral approaches, particularly with the dysmorphic pelvis and where devices are placed at S2 and S2-3. And it's reasonable to consider that this should be done in a hospital setting, particularly with backup by trauma surgeons and interventional radiology for that rare event where it happens, and it can be a life-threatening event. It's suggested that providers inform patients about the risks delineated in this talk that are specific to the lateral approach and the different risk profiles with other types of procedures. The next thing, it's important to inform all patients that if they're in that unpredictable group that has a failure, that's 15 to 20% of cases, there's no way to predict who that's going to happen with, and that revisions are challenging, and there are other FDA-cleared devices that are easy to revise, and therefore, because there's not enough surgeons doing it, it may be irrevocable. So next, it's important to inform all patients that there are unavoidable risks specific to lateral-based devices that do not apply to other FDA-approved devices, and surgeons that are performing the surgery should be competent and proctored in the 9 categories described by Bruce Dahl in his article that just came out. I recommend you read it. And all spine societies, not just SIMEG, need to claim this as their baby and be actively responsible for teaching all aspects of treatment, regardless of the mechanism and device used. And proper training needs knowledge of how to diagnose, mentoring, supervision, repetition, practiced understanding of fusion principles, including joint preparation and fusion techniques, understanding variability of the pelvis, understanding vascular and neural anatomy, particularly for the lateral approach, knowledge of the 3 major different approaches to the SI joint, proper CT and other appropriate planning, uses of image guidance, knowledge of how to revise and how to manage complications acutely, particularly revision and vascular injury. So I don't think we're there yet, regardless of the amount of RCT data or the lack of RCT data for other devices. Our goal, I think, is to have continued open data and innovation and randomized controlled trials, and to let the process play out. We need safety, utilizing safe bone and safe soft tissue corridors. The final product needs to be effective. The final product needs to be quick without fiddle factors. It needs to be reliable. I think it's achievable to reach 95% efficacy with greater than 50% improvement. That's an important goal. It has to be teachable, durable, including, I believe, an actual fusion of the sacrum to the ilium, reproducible by multiple types of providers. A safe 2D imaging protocol would be fantastic, easily revisable and easily supplementable if it fails, and accommodates pelvic dysmorphism. So we have a long way to go. I do not think that where we are is the final iteration. It's a great start for an orphan disease, but we've got a lot more to go. My wish, my hope is that these exclusive contracts that stop innovation are dismantled. And I think it's important for safety and for our patients and for the doctor-patient relationship to make sure that this innovation continues. Thank you.
Well, thank you, Tom. That was a very thorough and thoughtful presentation, provoking a lot of discussion, I'm sure. And I think it would be fair, before we move on to the next speaker on the ethical concerns of the use of exclusive coverage contracts, that we allowed Dr. Pauly to weigh in on some of your comments and get his thoughts.
Thanks, Jeff. So Tom and I have had significant offline discussion. And so I don't say much that he hasn't heard from me before. I think we all are victims of our last complication. And when we have a complication, it changes who we are as surgeons. I don't think there's any question about that. And so the question is not, can complications happen? They certainly can. The question is, what is the best data that we have? And what are the best strategies that currently exist? And then how do we continue to make them better? So what Dr. Freeman has shared with us is significant anecdote. Anecdote has a place. Anecdote is not the same as prospective data. And I look forward to published high quality studies showing me a better way. And when those studies come out, I will probably change what I do. I've made some notes going through as Tom has made different comments. And I would suggest that there are some analogies that are appropriate, some analogies that are more challenged. I don't think that revision is that difficult. I think that, I've had the opportunity to revise 7 different types of SI implants. They all have their own nuances. That revising lateral to medial implants, I found using the lateral interbody retractors where you can directly visualize it actually makes that quite obtainable, and that several of the companies have device removal strategies that are specific to the devices. Okay, our total joint colleagues get underpaid and are under-resourced for total joint revision, and they face that same problem. And so I don't know that revising a lateral to medial approach is harder than a distraction intra-articular arthrodesis, because when I've removed those, that's left a really big hole and created its own set of challenges. So revisions are challenging, no question about it. Anatomical structures are at risk in everything that we do in surgery. Knowing them gives us the best opportunity to avoid them. I personally called Chip Rout, who for the orthotraumatologists, he's probably well known as the best pelvic trauma fixation surgeon in the country and maybe the world. Chip told me he's done 5,000 iliosacral screw placements for trauma. He's had 3 vessel injuries that he's reported, all 3 of them. And he had a couple of comments about technique that I thought were very insightful, some of which I had wandered onto on my own, but Chip articulated them very nicely. Number 1, when you go through a muscle corridor, using an oscillate, not rotate approach does less damage and is less likely to wrap something up. And he actually uses an oscillating, not a rotating drill when he's putting in a screw. Okay, I think that's a really useful thought. When I do my soft tissue dilation, I oscillate, I don't rotate. Same thing with soft tissue sleeves when I put them down. I do all of my SI fusions with 3D navigation, as John Stark did when he was practicing at the same hospital, doing distraction intra-articular arthrodesis. And I think that that enables more precise placement. And so that then becomes a surgeon and facility judgment about resource allocation to technical accomplishment of procedures. I would take a different interpretation of the data about fusion and fixation than Tom has. I've had the opportunity to remove well-fixed implants. One patient was referred to me who developed a titanium allergy after she'd had bilateral SI joint fusions, and she was referred for that removal. The bony ingrowth, on-growth, and through growth in the removed devices was quite substantial. And so there was bony bridging across the joint. And so that does occur. In terms of blocking revision pathways, any metallic device placed anywhere in the body precludes certain strategies, but enables others. And the strategies range from removing the device to get access to that bony corridor to picking another bony corridor to go around. And again, my experience with navigation technologies enabled me to place S2AI screws around SI fusion devices of various brands. So I guess the bottom line is that clearly Tom has articulated a challenge that he has encountered. It has led him to a particular approach, again, based on anecdote, and he's done his best efforts to try to make conjectural analysis on data. And that what I look forward to is high quality data using alternative strategies. And when that high quality data comes out, then we can talk about comparative effectiveness. Until then, I think we're arguing that a Ford is better than a Chevy or vice versa. And maybe Tom likes Tesla better than Ford or whatever. But the bottom line is that the data to date is the highest quality data is on the lateral approach. And I look forward to the emergence of higher quality data and allowing us to optimize our care for patients. Because that's what the patients really care about is, have we given them adequate pain relief? They don't really care what direction we go, whether we use a Ford or a Chevy, or I'm sorry, for my German colleagues, a Mercedes, which is perhaps better than the Ford or the Chevy. But the challenge of high quality data remains. And until then, it's anecdote and conjecture, which may or may not be accurate. So.
Well, thanks, David. I appreciate that response. And obviously, this is going to take a lot more than just this conversation today to get to the bottom line. And I do know that Dr. William Cross from the Mayo Clinic, his an orthopedic trauma surgeon, is on. And I would like to get some of his ideas, since he is a trauma surgeon with a lot of experience. And most of us are spine surgeons or neurosurgeons with very limited exposure to the pelvis in our routine procedures. So with that, I would like to ask Dr. Cross to kind of weigh in on his experience, as you mentioned, with trauma, and why he thinks he could make this safer.
Sure. Just slowing down. Can you guys hear me okay? Little nod if you
There
can
you
hear
are.
me. Okay,
Yeah, we do.
fantastic. So first of all, I appreciate, I missed Dr. Polly's talk. And for those of you who don't know, Dr. Polly trained me, and really he and both Dr. Stark really introduced me to at the field of SI. So I owe them a lot, and then great friendships with Jeff and Tom. But anyways, I don't think the revisions are that hard. I'll second that. I'm also a Tesla guy. To make that clear. But my complication profile, when we talk about the different lateral-based approaches, I've been a lateral-based approach, being a trauma-trained surgeon, and I trained with Chip Rout for a year at Harborview. And I have had zero vascular complications, and I've been doing the lateral approach for trauma and SI fusions. And I think I've probably put in, to include trauma and SI implants, over 1,000 lateral-based screws. So it's been limited, but I spent the year in training looking at the pathways. I oscillate, to Chip's point when he was talking to Dave. So I think that Tom's presentation was also right on with education and in training and ensuring we're not relying on product representatives to tell us when the screws are in the safe zone. So I think we're just really emphasizing those education facets will be important going forward for any company. So I don't have much more to add. I don't think I'd love to answer any questions, about our vision practice or primary practice or my exposure with SI joint fusions. But I'll turn it back over to Jeff and the group.
Thank you, Woody. I'd like to ask you specifically, do you think there's a corridor that's safer for the lateral and the number of devices you place? I mean, there's a lot of things we need to work through that I think Tom brought up very, thoroughly. What is your thought on, I know you primarily stay in the S1 corridor with, based on your pre-CT scan imaging with orthogonal cuts and planning very, very carefully.
Sure. So the vast majority of cases are, and then as trauma surgeons, we sort of try and ignore the verbiage of a lumbralized vertebral body or sacralized L5 or an L6. So we simply use upper sacral segment and lower sacral segment, and then we look at the dysmorphism of the sacrum. And the vast majority of patients have, at least a 15 or 16 millimeter plus safe zone, which is in the S1 corridor. In patients that are dysmorphs, obviously their lower sacral segment, or S2, is the largest safe zone. So all of that is based upon preoperative planning, and really my philosophy that those that have heard me kind of espouse my way to do it. I love to grab the vertebral body bone because I think that's the densest bone in the body, and really force some compression and purchase into that vertebral body bone. So whatever safe zone I can get through, whether it's upper or lower. That's really how I determine where I'm going to go. And, safety profile, those are safe. We just got to avoid L5 and S1, and you know right where they are. And utilizing in and outlet fluoroscopy for me or navigation will help you avoid those and select your safe corridor. But I can't emphasize enough the preoperative planning aspect of an axial CT with coronal obliques to plan your pathway and recognition of the dysmorphic sacrum.
Thank you very much. And I know you have surgery to do, a couple of revision SI fusions, I understand. And I want people to know if they're in trouble and they have a difficult case, the Mayo Clinic and Dr. Cross and his team has extensive experience. And if I have a tough case, that's where I'm going to send them. And that's a really valuable resource for us. So thank you, Woody, for that. I know you have to go. So what I'm going to do is then move forward then with our next speaker. As I mentioned, on the ethical concerns of the use of exclusive coverage contracts by insurance companies for specific devices. So with that, I'd like to introduce the next speaker, Dorothy Vawter, who is a senior ethics and health policy consultant at the Minnesota Center for Healthcare Ethics. And it seems like Minnesota is like the center of the world for SI joint at this time. So Dorothy, would you please take over?
Good morning. Can you see my slides?
Yes, I can.
Great, wonderful. Thank you. Thank you. Thanks for this opportunity. Now we'll get down into a narrow topic, this question of exclusive coverage agreements. I think what we want to do today is explore the import of SI Bone's exclusive coverage agreements. So what are they, and what is known about these things, and how common are they, and what are the trends in this area, and where do they fit in health policy? And make a few policy and ethics observations. So I started out with looking to the literature, and very strikingly, there is no literature. Nothing comes up when it comes to ethics and policy discussions in the literature of these things. Is that because they're so new, because there's so few of them? So I had to look elsewhere for clues, and so these are some of the places where I've found relevant information. And certainly SI Bone's marketing materials, their press releases and quarterly reports. Some payers and specialty benefits management companies make their clinical guidelines available to the public. We have some formal objections by professional societies to iFuse's exclusive coverage arrangements. And we've had some payers and others revise or retract exclusive coverage agreements that they have with the manufacturer. And then I've had a number of personal communications with spine surgeons, health law faculty, and people in the manufacturing and payer worlds. So there is one piece of literature in health policy written by a professor from Minnesota. Professor Monahan is at the law school at the University of Minnesota, and she's written a very insightful analysis of trends in payer strategies regarding medical necessity coverage and the handling of denials, though she does not explicitly discuss exclusive coverage agreements. And just to note that there have been some court cases in which there are concerns about companies providing rebates for exclusive status. So when we look at the list of manufacturers that have FDA cleared devices, as I understand it in the SI joint fusion world, we have approximately 25 different companies, so presumably at least 25 different devices. But when we look at the FDA cleared devices that have an exclusive coverage agreement, it's not surprising there would be only one, and that one, of course, is SI Bone. So looking at some of the kinds of language that you find in SI Bone's materials, they refer to having, done to RCTs and many other things that they've contributed to the literature that has brought them near universal coverage. And that makes a lot of sense, and that's well deserved. The next thing is that it's near universal coverage for when this procedure is done exclusively when it's performed with the iFuse implant system. And they refer to this as offering proprietary reimbursement advantage. And their materials also inform us as of January 2020 that they had exclusive policies with 35 different US payers. But these ECAs don't just exist in the US. We know that France is exclusively covering the iFuse 3D device, and the UK is only recommending that the iFuse or the iFuse 3D be used. There may well be others, but just to give you a sense, this isn't just a problem in the States, or a question in the States. So SI Bone puts out ads on Facebook, things like this, where you see that Anthem Blue Cross Blue Shield decided to cover it exclusively, and United Healthcare, when they decided to cover it exclusively. And in a April 2022 publication in an online news journal for the orthopedic world, have this ad, which they say that almost half of US patients have plans that require the iFuse devices, and they list a number of payers with whom they have exclusive policies. So I think what one can say about these arrangements is that they are primarily financial agreements between payers and manufacturers. And as I said, it makes, everybody wants positive reimbursement determinations, and that makes perfect sense when you've got a safe and effective intervention. But for a manufacturer, securing an exclusive coverage agreement far exceeds receiving a positive reimbursement determination, because you not only have a covered device, but you have the only covered device. And all competing manufacturers are immediately, all those devices are rendered experimental, investigative, and excluded from coverage. So clearly what we can see is the manufacturers gain increased market share. There's drastically constrained competition. They get great rewards for their R&D. And of course, there are profits. Payers and the specialty benefits management companies, they get things like rebates, and they get to exclude the appeals when that drastically cuts down their staffing and administrative costs. And so they can be far more efficient and have lower expenses, and they certainly get some competitive advantages in the payer marketplace. So these exclusive coverage agreements, they're consistent with a string of other payer strategies that are being used to restrict the scope of medical necessity and limit coverage. Because it can support coverage denials then based on contractual agreements with patients, rather than based on things that we have traditionally included, like surgeon expertise, case-specific clinical rationales. So some professional societies have gone on record as objecting to the iFuse ECA. The AANS, the AAOS have written a couple letters to the United Healthcare objecting to this, the iFuse ECA, and noting in particular, and some of these are quite recent, like August of this year, and noting that AIM Specialty Health has retracted exclusively requiring iFuse. So they, when they retracted the exclusivity requirement, they replaced it with including any FDA-approved structural device with fixation. And then we have some payers that have retracted iFuse exclusivity requirements. Anthem Blue of California and Blue Cross Blue Shield in Minnesota is now covering open as well as minimally invasive with FDA-approved devices. So what started in April has changed in just 6 months. You can see that there's already quite a bit of change in exclusive policies. There's been some retreat from that by United Healthcare, Anthem, and some of the Blue Cross Blue Shield plans. So it's just some general policy observations I'd throw out there. I think it's very unclear what ethical and policy commitments are motivating the specialty benefits management companies and payers and manufacturers to adopt these exclusive agreements. What regulatory or legal forces, if any, are driving them to consider the interests of patients, surgeons, healthcare organizations? Because it permits the payers to attend to medical necessity just at the front end when they're structuring an agreement of this sort, and then they can use contract law to refuse to attend to medical necessity when confronted with the particulars of a specific patient. So they have the effect of stripping patients and surgeons of rights to appeal denials or seek exceptions. And one has to wonder what accountability the payers should have for these proprietary coverage plans with uncontestable coverage decisions. It's unclear how some of these, what might be potentially at least inappropriate limitations on surgeons and patients, how are they best addressed? We don't know. Regulation, new laws, professional society advocacy, class action lawsuits. So they also clearly are putting a damper on competition, innovation, and quality improvement. Another thing I would note about exclusive coverage agreements is that they just seem to conflict with a lot of different efforts in health policy. There's a lot of federal and state initiatives around consumer protection and trying to level the playing field between patients and payers, and there's ACA's been involved with that. That's certainly the National Association of Insurance Commissioners. There are fair coverage initiatives that really emphasize the importance of transparency and responsiveness and robust appeals procedures. There's increasing attention to real-world evidence when we are engaged in safety and efficacy assessments. And certainly, conflict of interest and anti-competitive management strategies. All those are other health policy commitments we have that it's unclear how ECAs are consistent with those. So just with the ethics lens on ECAs, it seemed to discount and disrespect the expertise and professional judgment of surgeons who are specifically trained in the treatment of SI joint dysfunction, and obstructing their obligations to protect and advocate for patients' best interests. And any failed surgical outcomes are falling on the surgeon whose hands have been tied by payers who have ECAs. And they're essentially functionally empowering payers to practice medicine while themselves evading accountability for bad outcomes. So that it's, fairness certainly can be raised around this issue of revoking patients' rights to apply for exceptions and permitting these financial considerations and even conflict of interest to influence the development of these agreements in non-transparent, in proprietary systems. So they tend to unfairly favor manufacturers who are blessed with large research and marketing budgets over smaller manufacturers, and to favor payers who are unwilling to accept appeals and who will not cover more expensive procedures. On the issue of disclosure and consent, I think one could observe that they introduce some novel disclosure burdens on surgeons. I think it makes sense for them to disclose when an implant surgery is against medical advice, but is being offered because it's the only option the payer is contractually required to cover, and to debunk the belief that there is really literally a single medically necessary surgical intervention for something as complex and variable as SI joint dysfunction. Disclosure about this patient's lack of opportunities to appeal. So, and disclosure can offer providers some protection, and I think reasonable people would want to know, the reasonable person would want to know some of these aspects of exclusive coverage agreements. So summing up, I would observe that ECAs seem to be new, unfamiliar, they're unsettled and disruptive because they fail to align with major other health policies. And we can observe that there's great variation among payers. There's the payers who consider any FDA cleared device as at least potentially medically necessary, versus determining that only a single device in this space is medically necessary. Clearly, the payers and manufacturers get some very significant financial benefits, but they raise these agreements, exclusive coverage agreements, raise significant unaddressed policy and ethical concerns for other stakeholders. And they seem to be existing at this time anyway, without any real clear, well-publicized and understood ethical and policy justifications or constraints. So I think this is a topic that definitely deserves more sustained scrutiny and further considerations regarding when these kinds of arrangements may be appropriate. And lastly, there is movement in this field, this area. We see jostling, we see payers adopting, then revising, then retracting ECAs. So change in medical necessity and coverage policy and practice is occurring really quickly these days and abruptly, and who all is driving these changes? Well, I think professional societies have a role to play, and perhaps even a key leadership role. So I want to thank SIMEG for hosting this symposium and for providing this opportunity to consider the risk-benefit profile of iFuses, as well as having a chance to discuss ways to improve the field of SI joint fusion generally.
Well, thank you, Dr. Vawter.
Acknowledge a couple of folks, and that is it. Thank you. Thank you so much for the opportunity.
Thank you. Thank you, Dr. Vawter. I think it's important to mention part of the energy behind this discussion, and I'll let Dr. Freeman speak to that, was the patient that he had this near miss or near fatality was basically, he was dictated to use a specific device. And that obviously led to a lot of the conversations we're having now. And I do hope that the SIMEG, the Sacroiliac Medical Expert Group, will be a resource for clinicians and patients, so we can all get together to move forward with what we believe is this revolution in evolution. And the reality is it needs to evolve. It needs to evolve on the concepts that we're discussing today and many other fronts. But I'd like to have Dr. Polly have a chance to kind of respond to that if he'd like to.
Thanks, Tom. So, I actually, well, I actually had the opportunity to ask a former medical director for a large Blue Cross Blue Shield company about this question and topic. And I think what Dr. Vawter indicated about them resorting to contract language is that's the view that they take, is that this is an agreement for management of a financial relationship for covered versus non-covered medical benefits. And that's the line that they go back to. And so how we get to optimal access for patient care is actually an increasing burden on the medical community, with prior authorization challenges just escalating like crazy. And so I've been a part of American Academy of Orthopedic Surgeons advocacy efforts on a number of topics. And the payer side has just been really, really challenging. And that the only thing they have responded to date has been high quality data. And so the high quality data seems to be the best pathway to success, and that other strategies for getting payer movement have been less successful. And in terms of the exclusive coverage, it's really been payer decisions rather than, I think, thoughtful or not thoughtful engagement from industry that have led to these decisions, at least as I understand them. And so it really comes back to available data, and that with available data that drives decisions. When we're faced with all we have is opinion and experience, we don't do so well.
All right, thank you for that response. Dr. Freeman, do you have another comment related to how we got here?
I think it's pretty well been covered. I think it's really important to say good data should lead to coverage, but the exclusive coverage, when there are numerous other FDA-approved devices, is a novel issue, and it is a problem with patient safety because it stops research and development. If other companies can't do clinical trials and can't get patients on the OR table, how do you do a clinical trial? Because no company can self-fund every operation when there's predicate data. For example, the distraction interference technique has been done safely for almost 20 years, and there are FDA-approved, devices, and then all of a sudden it becomes experimental 20 years later. That's just wrong. And so there's a real concern with how do you meet patient safety when you destroy the ability to innovate. So I think the net result is great for companies, but bad for patients.
Well, I think, this is a very good conversation, because I think the reality is this is really on an exponential pathway in terms of not only the problem being identified, but the problem increasing. And I think a lot of that has to do with the fact that we live longer. A lot of our patients are having long fusions down to the sacroiliac joint, adding stress and increased chance of pain. Obviously, obesity is adding another factor. So with that, we need to have all our disciplines, whether we're surgeons or primary care providers like therapists and chiropractors, being involved in knowing when to refer patients. But I think in between there are the interventional pain partners that we have, who are going to play a big role. And I understand that they are dominating or beginning to dominate the market in terms of treatment in their algorithm, from injections of one substance or another, including increased use of regenerative medicine, but also radiofrequency. And having this surgical option in their armamentarium is clearly where this is heading. And we want to make sure that all of us, who, no matter what specialty we are understanding all these potential risks, the advantages and disadvantages, and we work together, because obviously the patient is who we're seeing in the office, and we want to see a safe, effective, durable result because that makes you a happy person, and that makes them a very happy patient. So with that, I'd like to see if we have any other comments, either from Dr. Polly or the audience, and go from there. I do see if Dr. Polly didn't want to add any more, I'll give him a minute first.
Jeff, thanks. I don't really have anything further to add, and I apologize that I have to run to my next obligation. Thank you for the opportunity to participate.
No, we very much thank you very much. With that, I see, maybe I could just see if Bruce Dahl, for example, or ask a question. And there's John Stark as well. Sorry, John.
Thank you.
You're on, John. I see you're on.
Thank you very much. Well, I very much appreciated the discussion. I would have a hard time putting my concerns better than Tom Freeman has on the parallel. I think they're the academic side of it compared with the individual circumstances of patients which present with these lesions, the paralysis, the bleeding, the irreversibility. It isn't a statistical game. It's not like you can put up these curves and demonstrate what the outcomes should be or what the decision making or the choice of the implant should be. I did make a presentation at NASS last weekend, actually, on the safety and recommendations for safety in this sacroiliac fusion. And the revisability thing is one thing, but the concept of a never event should be introduced here. The never event in orthopedics is like cutting off the wrong leg, let's say. There isn't a statistical game here that will allow that to happen. And if a surgeon who is otherwise trained in anatomy drills across an artery or a nerve that he does not or she does not know is there, that's a never event. And the patient, it should not happen. And to review the MAUD database, and we have, and we reported this as part of this presentation, there were 1,500 never event, I should say complications, what they call injuries, in this list of situations back as far as 2009. And the incidence of these problems is not decreasing with time. And the 3 deaths which did occur should have been never events, I think. They're not statistical things. There are other things we have not talked about. We have not talked about the biomechanics. We have not talked about whether or not there's a deformity here, which I believe there is, which has neurological implications, and we can demonstrate that. And I really can't go by the buzzword kinds of things where we're victims of our last complication, or we all get complications. That's poorly expressed in the circumstance of some of these severely injured patients. And I have seen them in wheelchairs, and I have seen them without bowel and bladder control. I have seen them without sexual function after the laterally based approaches. And it never occurred to me, truthfully, it never occurred to me that I would want to fuse a sacroiliac joint by going from the lateral side. It just never struck me as biomechanically or anatomically correct. And I think that's borne out by the kinds of things which Tom Freeman has now articulated. So I would go along with his recommendations about having PAC cells available. I would add that the companies should be instructing on this vulnerable anatomy and the preoperative imaging, which they don't do. They should provide a better salvage circumstance, which they don't do. And failing all those kinds of things, these complications should be expected. And expecting never events seems inherently contradictory to me. So that's all I have to say.
Well, thank you. That's you've had a lot of experience in this world. I know you're one of the reasons SIMEG began. So thank you for that. And I just want to ask, I see other people on here, but Bruce Dahl, I see, is on, and he's been a leader in this field going way back, well before me, maybe in John's time, but I'm almost over 30 years, and I'm sure you're even longer. So I'd like to get your thoughts.
Thank Thank you, Jeff, for inviting me to this. 30 years ago, when I did my first SI joint fusion, I purposely avoided the lateral approach for all the reasons that Dr. Freeman so wonderfully listed. And my big concern today is that the entire SI joint fusion industry is completely run by industry at this point. They make the devices, they find the doctors, they do the education, and all that's good. The best thing about it is that they have, in their way, increased the awareness of SI joint pain in the entire world. And that's a wonderful thing. But the great challenge at this point is getting our surgical educational societies, NAS, CNS, and all the rest, AAOS, to begin educating surgeons about the whole of the topic of the dysfunctional sacroiliac joint. Our conservative treaters have been teaching this for years. They know all about it, but they won't refer their patients to surgeons because these patients are now cash cows in the revolving door of their treatment. So patients are really stuck. I believe that if the large educational societies begin teaching this, put out knowledge updates, start with the core of the dysfunctional SI joint, and make sure that surgeons know all about it. I mean, everything in this symposium should be in those courses. I think that's what's going to generate the change that we need in the future. Otherwise, we're all just kind of going our own directions, saying our own things. SI Bone is definitely a tremendous business organization with a lot of smart people. And the rest of us are trying to make our cases on antidotes. So I would encourage everyone to get their educational societies to get to work. That's all.
Well, thanks, Bruce. That's comes from 30 years of experience, and we don't have all the answers. Maybe there are ways to make lateral safer, and that's what we need to look towards. And obviously, John Stark feels very strongly that the one technique is the safest and should only be considered. But again, that is his experience and his data in his hands. So with that, we want to make sure we have a platform where other new technologies can prove themselves. And with that, I'd like to just kind of extend this conversation. I do see some non-surgeons in the group. Dr. Sager, I was wondering if you had some comments.
Well, I do. I have probably more minimally invasive surgical experience than most interventional physicians, but I've been doing sacroiliac joint related work. And by the way, I trained at Harborview, trained with the same institution with Chip. And even when I was in practice in Bremerton, Washington, I got referrals to do SI joint injections then because it was hard to find somebody who could reliably get into that joint. The problem is enormous, and it's one that interventional pain specialists are increasingly aware of. And the critical thing is to have a hand-in-glove relationship with the referring surgeons, and that's what we need to develop. I've been frustrated by the fact that the interventional techniques that are available have led to a real dead end. I learned how to do SI joint RF, and it's a largely worthless procedure in the sense of offering anything definitive. I've been trained and had certification with the Zyga technique, with the Samba screw technique, but I was inherently suspicious of the safety of those approaches. I did become trained early on in the corner lock approach, corner lock technique, and I've done 48 of those procedures, and then I quit because although they gave originally some very nice outcomes, they distracted the joint, they stabilized the joint, but the cortical bone dowels or squares eventually subside and don't fuse, and so I abandoned that technique. But I'm still convinced that the definitive solution for SI joint pain that doesn't respond to physical therapy and the occasional responder to in a definitive way to injections is a surgical solution. And so towards that end, my personal objective in the educational side is to help the Spine Intervention Society related members much more aware of what the surgical options are and how best to interact in a team approach so that we can bring these options available to patients. And I've gotten myself onto the program committee for next year's national meeting, and hopefully we will have an SI symposium there and hopefully have some participation from some of the members who are part of this meeting today, because I think that, as had been mentioned earlier, interventional pain physicians and a small subgroup of which who have some surgical skills that may be doing some of these approaches over time are going to be a bigger part of the care team. But most importantly, from the standpoint of working up the patient properly and having that kind of a team approach with the surgeons is going to be critical. And so I think we need to work to develop that kind of close relationship. And I'm going to work as hard as I can within the society that I have influence with to promote that objective.
Well, I appreciate that. It really does need to be, interdisciplinary to be effective. And we all have our different knowledge base and experiences. And with that, I think if everybody works to help the patient the best they can with the least risk and the highest safety profile that's effective and durable, then we win. But we're not there. It's still an evolution. And I really appreciate your comments and the fact that, we still need to look for ways within the pain management group that we can help these patients without taking higher risks. I do see there's some other, unless I see a hand up, I'm trying to slip through the names here, but if there are any other pain physicians who would like to follow up on that conversation that Dr. Sager had, that'd be a good time. And then any other surgeon comments?
I only wanted to I'm going to have to leave, but I wanted to follow up just and reiterate a theme that I think came out of the symposium from what I've seen so far, and that's education and, appropriate training. And that, I know that vascular complications are out there, and I know that, Dr. Stark has seen a few, and Dr. Pauly has seen a few, and Dr. Freeman has seen a few. And, these things do happen with people, and they should be never events. And, but raising education and awareness of anatomy and where the safe zones are and where you can put your implants can minimize those is such that they can be never events. And, I'm sure that my time is coming, and I'm not Chip Rout, where I've done 50,000 screws and have had 3 complications or 3 vascular injuries, all of which he's reported. I've done over 1,000, lateral based approaches for SI screws for trauma and SI joint fusions from a lateral based approach with 0 vascular complications. Also 0 neurologic complications. And I think knowledge of where you can put your pins and where you can is critical. I've oscillated since day one. since for how to put in a pin. So that type of training I think is integral going forward. And as an SI joint community, to emphasize what Dr. Dahl said, the impetus is on us as surgeons to train people, not industry. And I know for a fact that there are reps out there who are guiding and telling surgeons where to put their guide wires and how far they can put their guide wires in. And that's where we're running into problems. So it has to do with training. And I love what Dr. Sager said, let's get our societies to step up and train people, not industry. So sorry for my little soliloquy there, but I'll sign off.
No, very thoughtful. Appreciate that because, clearly, if someone's doing something that's effective and safe, we need to know what the differences are. And that's why I think these meetings and especially discussions and, I think since you're mentioning Harborview, Jens Chapman, I follow his Seattle Science Foundation and listen to a lot of his lectures. And it's basically, he says, you discover something, you discuss it, and then you debate it. And the whole idea is, when we do that, then we're going to have closer to what we believe the truth is, where not necessarily intentional or non-intentional, being untruthful, but, a lot of the truths can be hidden, and we need to ferret them out. So with that, I'd like to, again, ask people to support the SIMEG mission. It's a very, very low cost admission, I guess you could say, to this society. 50 euro for colleagues, and industry is very reasonable at 500. And the idea of this is unrestricted so that we can continue to make progress. And without that, though, it becomes very challenging. And we are going to continue with these types of web-based meetings because of the situation we all know in the world, especially with the viruses that are mutating and creating difficulties getting together, especially internationally. So with that, I want people to look forward to more of these types of conversations. We'd like to have more input from the other disciplines to get ideas what to discuss. But again, this is primarily a group of surgeons trying to figure out how to help their patients, but we want to be educated by everybody. Is anyone else have any pressing things I'd like to say before we end this?
Jeff, this is John Stark again. I just got a text from one of our colleagues that pointed out that one thing that has not been mentioned is the differential diagnosis of extraaxial radiculopathy on the basis of sacroiliac change. And I would just encourage the group to chase that down and perform their physical examinations, attempting to differentiate between the radiculopathies caused by axial things and the radiculopathies caused by extraaxial things, and whether or not one approach has a better answer to that kind of question than another. That's all I had to say. Thank you.
Well, great, everyone. Look forward to the next meeting, and we'll be posting that on our website. So stay tuned and look up SIMEG International. Take care. Have a great day.